Ketamine. So ketamine is an IV anesthetic. Most IV anesthetics don't give analgesia. However, ketamine is an IV anesthetic that does give analgesia. Ketamine produces a cataleptic state. The patient's eyes will remain open, moderately dilated, and the patient will have a slow nystagmic gaze. With ketamine, lacrimation and salivation are increased normally. But pre-medication with an anticholinergic such as glycopyrrolate or atropine can limit those secretions. Ketamine is a phencyclidine derivative. Phencyclidine is also known as PCP, and if you think about Denzel Washington in Training Day, you can remember he said to the trainee he framed, "You've been smoking PCP all day." Fun fact. Ketamine is partially water soluble, but you should think of it as highly lipid soluble. It comes in racemic mixtures of 10, 50, and 100 milligrams per milliliter in the United States. Ketamine can have some unpleasant psychomimetic effects. However, ketamine is unique in that it provides potent analgesia and minimal respiratory depression. A couple of side notes here. Ketamine can be used as an adjunct to reverse opioid tolerance at a subanalgesic dose. It can also be used for major depression. I have family members who use it to treat major depression, and I see these clinics popping up around Houston to treat major depression. Ketamine infusions. It's very effective, apparently. Ketamine's high lipid solubility ensures that it has a rapid onset of effect. The effect of a single bolus of ketamine is terminated by redistribution to inactive tissue sites. Ketamine's metabolism is primarily in the liver via cytochrome P450 indemethylation process. The primary active metabolite from ketamine is norketamine, which retains 1/3 to 1/5 of the potency of ketamine. Norketamine is further metabolized to a water-soluble state as an inactive metabolite and is excreted in the urine. Ketamine is the only IV anesthetic with low protein binding. I saw that Miller said it was 12%, and on UpToDate I saw a larger figure, like 20% or something like that. But it has apparently low protein binding. I think I saw 24% on UpToDate. Ketamine primarily acts on the NMDA receptor complex, inhibiting glutamate, the N-methyldeaspartate receptor complex. So again, ketamine blocks glutamate at the NMDA receptor complex via non-competitive inhibition. If ketamine is given alone, amnesia, though present, is inferior to the administration with a benzodiazepine. Reflexes of ketamine administration are preserved, but do not assume that the patient can protect their own airway. Ketamine has some psychologically adverse emergence reactions, thus limiting its use and popularity. Patients may feel fear and confusion, maybe. They may be hallucinating. Children typically fare better than adults or the elderly, although this just depends. Again, use a benzodiazepine with ketamine to reduce adverse emergence reactions and to increase amnesia. Even sometimes in the older population, when you might want to avoid giving a benzo, you can consider it. Today I gave ketamine and 4 milligrams of midazolam to a 61-year-old female who was going in for a left foot debridement. Ketamine is a cerebral vasodilator that increases cerebral blood flow and the cerebral metabolic rate of oxygen consumption, unlike some other IV anesthetics. Avoid ketamine in patients with intracranial disease and especially elevated intracranial pressures. You can counter the unwanted cerebral effects of ketamine with normal capnia and controlled ventilation. And ketamine has the potential to produce myocardial activity, in other words, muscle jerks. However, ketamine is considered to be an anticonvulsant and can be used for status epilepticus when other drugs are less effective. So there's lots of different things that can cause muscle jerks, myoclonic activity. But the myoclonic activity you see in epilepsy is not what we're talking about here. Ketamine can just produce its own form of myoclonic activity. And again, this vasodilation stuff, the cerebrum and the central nervous system, you'll see later on in this presentation that there's some evidence, just like we say here, that if you maintain normal capnia and control the ventilation, that you can counter those. It's not necessarily a given that it will raise ICP, but it is sort of contraindicated in patients with masses or hydrocephalus, things like that. Ketamine can produce significant increases in systemic arterial blood pressure, heart rate, and cardiac output via its centrally mediated sympathetic stimulation. Again, blocking that GABA from binding to the NMDA receptor will cause an increased sympathetic response. Ketamine therefore can raise cardiac work and oxygen demand and consumption in the heart. The cardiovascular work increases can be countered that come with ketamine. It can be countered with benzodiazepines, opioids, or a volatile anesthetic. But just be aware of this. This is a bit controversial. Ketamine is said to be a direct myocardial depressant. However, this myocardial depression is typically masked by its transient sympathetic central nervous system stimulation. The myocardial depression you see in ketamine is more important in the critically ill patients who have a limited ability to increase their sympathetic nervous system activity. So again, you want to think of ketamine to be used in hypotensive patients. You want to think of it to be used in people who are hemodynamically unstable, but it does have the potential later on to cause myocardial depression because of this increase in cardiac activity. So regarding the respiration, ketamine does not produce significant respiratory depression. Arterial blood gas levels and hypercapnic responses maintained under ketamine administration, assuming you're not giving any other drugs. If one gives large induction doses of ketamine for anesthesia, ketamine can induce transient hypoventilation and rarely short periods of apnea. I saw this from two sources, one UpToDate and also Miller. So again, do not assume the patient can protect their own airway with ketamine. Ketamine has an increased risk of laryngospasm due to secretions, particularly in children. And again, you can counter those secretions with pre-medication anticholinergics. So, ketamine relaxes the bronchial smooth muscle. It may be helpful in reactive airway disease patients, aka asthma patients, and ketamine may be useful for managing patients experiencing bronchoconstriction. Ketamine has numerous routes of administration: IV, IM, oral, rectal, epidural. So intravascularly, intramuscularly, oral, rectally, epidurally. I've also seen a ketamine spray, nasal spray. Ketamine is therefore useful in mentally challenged patients, the very young, or otherwise uncooperative patients. Ketamine has induction of anesthesia dose at around 2 milligram per kilogram IV or 4 to 6 milligram per kilogram intramuscularly. I've seen the dose at 1 to 2.5 milligrams per kilogram IV. Ketamine is typically used for induction and not maintenance, although today I myself did use it mostly for maintenance and an induction on that foot debridement patient I was talking about. Ketamine has a short context-sensitive half-time, so its use for maintenance of anesthesia could be considered indeed. So here's an example of that. One can achieve general anesthesia via ketamine infusion at 15 to 45 micrograms per kilogram per minute in conjunction with a 50 to 70% nitrous oxide. So again, remember nitrous oxide has a MAC of 105%, if I'm not mistaken. So half a MAC would be about 50%. So if you want to do ketamine infusion alone for general anesthetic maintenance, you can go 30 to 90 micrograms per kilogram per minute. This is according to Miller. So another scenario for ketamine use might be regional anesthesia when some additional analgesia is needed, such as a C-section and an neuraxial anesthesia that has an insufficient regional block. You can give a small dose, which is all that you need, for additional analgesia, 0.2 to 0.8 milligrams per kilogram IV. Again, remember, no compromise of airway exists with ketamine, and serious pain control can be achieved. Today, we gave, in my case, ketamine, midazolam, fentanyl, and propofol, using only an O2 mask and no airway protection for a foot debridement. I think we ended up giving 50 milligrams of ketamine, 4 milligrams of midazolam, 50 micrograms of fentanyl, and 30 milligrams of propofol. Patient did pretty well. She was moaning a little bit throughout the case, but overall, I think she won't remember the case. Um, the only thing I would note here is that the secretions do present a risk of airway laryngospasm, but there's no respiration depression. That's the important part to keep in mind. So a ketamine dose of 3 to 5 micrograms per kilogram per minute during general anesthesia and an early post-op period may provide useful analgesia or reduce opioid tolerance or reduce opioid-induced hyperalgesia. There's some studies that support this and some that don't. But just remember that. It's kind of a nice pearl to remember. You can reduce their pain in the early post-op period with a small ketamine dose during general anesthesia or to counter opioid-induced hyperalgesia. Case reports do show that CNS effects of ketamine can be mitigated, but still with analgesic effects by local and topical application of ketamine, as the NMDA receptors on peripheral nociceptors can theoretically be inhibited, as you can achieve high local concentrations without systemic involvement. Yeah, this is just something Miller was talking about. You can have some local uses for ketamine, perhaps. Again, these are case reports, not given lots of double-blind studies or anything like that. An induction dose of ketamine is around 1 to 2 milligrams per kilogram. Ketamine may cause myocardial depression and hypotension in critically ill or catecholamine-depleted patients, so remember that. But normally, under a healthy hypotensive patient, ketamine would be a good choice. There's no expected change in respiratory rate, ventilation volumes, or hypocapnic response with ketamine. Systemic vascular resistance, systemic blood pressure, and heart rate are expected to increase with ketamine. Cerebral blood flow, cerebral metabolic requirements of O2, and intracranial pressures should increase or not change with ketamine, according to Miller. Ketamine does not cause or reduce PONV. Ketamine does not cause adrenocortical suppression. Ketamine does not cause pain on injection. This adrenocortical suppression point, I'm going to have to get back to you on. I think it's correct. I believe Miller did say this. But I seem to recall that that may or may not be the case. For emergency situations with active hemorrhage, a general anesthetic may be required, and you could use etomidate or ketamine, a dose of ketamine around 1 to 1.5 milligrams per kilogram. Imagine someone comes in, they're hemorrhaging, they may be hypotensive. If you need to put them under general anesthesia pretty fast, ketamine is definitely an option. You don't necessarily want to give propofol, right, because they may have systemic collapse. So ketamine's a good choice there. So, some considerations for ketamine. Consider administering ketamine IV bolus doses over 30 to 60 seconds to reduce the risk of respiratory depression and apnea. For the obese, consider using the ideal body weight or the adjusted body weight doses for initial boluses of ketamine, and then later titrate to effect, or adjust as you see fit. If an initial induction dose seems inadequate, wait 5 to 10 minutes and repeat the bolus at half a dose, which may be 0.5 to 1 milligrams per kilogram, given your baseline of 1 to 2 milligrams per kilogram. This isn't common at the upper end of the normal dosage range, though. The need to, if you go at 2 or 3 milligrams per kilogram induction dose, you don't necessarily want to give them another bolus of 1.5 milligrams per kilogram. That seemed to be the point that was being made. So consider also if the patient is hypotensive or likely to develop hypotension from induction, you can use ketamine as an adjunct to the induction process. So, some other things. Ketamine has no renal impairment dosing adjustments. Ketamine has no hepatic impairment dosing adjustments. Dosing for ketamine is titrate to effect in pediatrics, and again, consider the use of anticholinergics to reduce secretions. Ketamine is considered absolutely contraindicated in patients under 3 months old, infants, by the American Emergency Physicians College due to airway secretions. There is adjusted dosing for children and alternative routes of ketamine in UpToDate. The American College of Emergency Physicians also says known or suspected schizophrenics are absolutely contraindicated against ketamine, even if they are well controlled. There's a Canadian label warning that says a contraindication to ketamine is a history of CVA or a surgery of the pharynx, larynx, and bronchial tree without additional muscle relaxation, because remember, it can cause those bronchioles to open up. Patient delirium may continue up to 24 hours post-operatively with ketamine. 24 hours. To reduce this perioperative delirium, you can avoid verbal or tactile stimulation of the patient in this time frame. So if the patient's coming out of it, they don't seem like they're having a great time, go ahead and consider not stimulating them. So again, the intracranial pressure or central nervous system pressure effects may be reduced with adequate ventilation in ketamine. So use with caution if you're going to use it, but just realize that you can counter it by keeping their end tidal in the appropriate range. So price of ketamine is around $1 to $3 per milliliter at the 10, 50, and 100 milligram per milliliter concentrations, American pricing. So today we gave 50 milligrams in 5 milliliters, and we used the 10 milligram per milliliter concentration. So that probably cost, what, $5 or so? $5 to $10 at most. Pretty cheap, considering we did the whole anesthetic with ketamine and some other drugs, but ketamine was certainly the cheapest part of their anesthesia today. The onset of ketamine is within 30 seconds when given an IV. Intramuscularly, you're looking at 3 minutes to get some dissociation and 10 to 15 minutes for the analgesic effects of ketamine. IV anesthetic effect of the duration of the IV anesthetic effect of ketamine is 5 to 10 minutes with recovery in 1 to 2 hours. That's what the article on UpToDate said. Today I heard it's longer, 30 minutes really. We had to give boluses of the ketamine about every 20 or 30 minutes, but 10 milligram, 20 milligram boluses. But apparently the IV anesthetic effect is considered to be 5 to 10 minutes. The alpha elimination half-life of ketamine is 10 to 15 minutes. The beta elimination half-life of ketamine is 2.5 hours. Ketamine's excretion is 91% in the urine and 3% fecal after it goes through that liver metabolism. These are my sources. I used Miller's Basics of Anesthesia 7th edition 2018 version, pages 114 to 117, and page 574. I also looked at an article on UpToDate called Ketamine: Drug Information Lexicon. I accessed it today, Friday, October 9th, 2020. And I'm considering making some review questions from Miller's Basics of Anesthesia review in the future. All right.